Hi guys, welcome back to the second part of the introduction to clinical orientated anatomy. Today we're just going to continue on and we're going to start to look at the integumentary system. As I say, these are just the introductory videos, so we'll really just highlight a few points and then really get into the nitty gritty of it over the next few weeks. So the integumentary system. The integument, Latin integumentum, which means to cover, ranges between 1.5 and 2 square meters, and it accounts for some 12 to 20% of the whole of the body weight. Ranges anywhere from 1.5 and 4 millimeters in thickness. It's also known as the cutaneous membrane or the cutaneous layer. The integumentary system covers the surface of the embryo, the skin, and its specialized skin structures including hair, nails, sweat glands, mammary glands, and teeth. And here we can see an example of a cross-section through. We can see the epidermal layer, the epidermis, the dermis, and the hypodermis, and we can see the structures and the various structures displaced throughout. The functions of the skin are for protection of the body from the environmental effects, containment for the body structures and vital substances, preventing dehydration by limiting fluid loss, heat regulation through the evaporation of sweat and or the dilation or constriction of superficial blood vessels, sensation by way of superficial nerves and their sensory endings, and synthesis and storage of things like vitamin D. The structure of the integumentary system: we have the epidermis, the dermis, and the accessory structures. So within the epidermis we have stratified squamous epithelium, we have a basement membrane. Within the dermis we have loose connective tissue and dense irregular connective tissue, and within the accessory structures we have hair, glands, and nails. And we'll start to look at these in more detail as we go through our histology and our introduction to histology. So one of the things that we're going to talk about when it comes to the integumentary system is burns and classifications of burns. Burn wounds can be classified into 6 separate groups based on the mechanism of injury: scalds, contact burns, fire, chemical, electrical, and radiation. We have something called burn grading, which is to do with how much the burn has gone through the tissue. So we have something called a first degree, a second degree, and a third degree. A first degree, also called a superficial burn, we can see is affecting the epidermal layer. A partial thickness or a second degree burn is affecting the epidermal and the dermal layer, and a full thickness burn goes all the way through these layers. The rule of 9. The rule of 9s is the relationship of skin coverage and burns to different parts of the head. So for instance, if somebody has burns to both parts of the anterior thighs, the legs and the feet, these are the percentages in which a person is considered to have burns. So an anterior and posterior thighs, legs and feet, the person is considered to have 36% burn. Or if for instance we had an anterior and posterior head and neck, we would have a 9%, anterior and posterior arms, forearms and hands, and 18%, anterior and posterior trunk. So if somebody was in a house fire and they had been burnt really heavily on the anterior and the posterior trunk, they'd have a 36% grade burn. We have something called the Raynaud's phenomenon. Raynaud's phenomenon is to do with poor peripheral circulation. And so here we can see, in this case, patient, the bluing of the fingers. So we'll start to look at this. Other signs and symptoms that we can see within the integumentary system. Signs of jaundice. Jaundice appears of yellowing of the skin of the integumentary system. Carbon monoxide poisoning. We see this blue purpley tinge to patients who have had acquired carbon monoxide poisoning. Scarring is something that we will often see as physicians, clinicians in practice. So skin is just not arbitrarily draped over the body. It develops in such a way that it has lines, and these lines are called Langerhans lines. And these lines are important because certainly as you go further into your training and become more involved in surgical training, you need to know how to plan incisional lines following Langerhans lines of cleavage. So in this diagram, this rather strange looking diagram that we have, this shows the lines in which the cleavage lines appear. So what it means is that when somebody receives a cut or a gash, like a stab wound or a gaping wound, the wound will not heal if opposed to the lines as much as when running with the lines. And this is the reason for certain surgical incisional approaches. So we can give you an example here. If we did, say, an appendectomy, although it's really laparoscopically now, but if you were to do an appendectomy and see an appendectomy scar, the appendectomy would follow the lines, as opposed you wouldn't see an appendectomy that was performed like so, because that would be transecting the lines, and that would give a very large scar. You'd get a much bigger scar. And then of course you can see just how important this is when you consider the face, because look how complex the lines are when it comes to the face. And so that becomes very important when you think about things like cosmetic surgery and the different lines and incisions. And we'll come back and talk about Langerhans lines more as we progress through. So let's start to look at the germ layers and start to link some of our embryology, anatomy and histology together. Or I should say start to introduce. So in the last video I introduced you to ectoderm and mesoderm. So the germ layers, the germ layer origins, we have the ectodermal layer, which forms the surface of the epidermis and the associated glands. So here we have the surface ectoderm, and underneath we have the mesoderm. The mesoderm, the somite origin, forms the underlying connective tissue of the dermis and the hypodermis. And the neural crest cells migrate into the forming epidermis and the skin, and is also populated by specialized sensory endings. So we'll just have a little bit more of a look at this picture in a bit more detail. And this is going to introduce you to histology a little bit more. So here we have a cross section. We have the surface ectoderm, and we have the mesoderm. So this is the outside world, and here we have the inside world. We have the periderm, the proliferating basal layers, the dermis, the melanoblast and the dermal papilla, all of which we'll start to identify as we go through our histology over the next few weeks. So I just want you just to start to remember and look up about these layers and what we would expect to see, what cells we'd expect to see, what structures we'd expect to see, what the functions of these structures are, So we really have to link in quite a few different subjects, including physiology and indeed cell signalling. So we need to think about cell biology, and we also need to think about the overall anatomy, and then put the clinically relevant points in as well, different degrees of burn, etc., etc. So the epidermis, let's go through the embryological developmental stages. So initially the embryo is covered by a single layer of ectodermal cells. We have the ectoderm and the mesenchyme. From week 4 to week 5, in the beginning of the second month, this epithelium divides and a layer of flattened cells, the periderm or epigym, start to form. So here we have the periderm. This is from week 4 to week 5. We have the basal layer. Here we can see the basal layer. The epidermis, the peridermal layer. The cells of the peridermal layer continually undergo keratinization and desquamation to be replaced by cells arising from the basal layer germinative layer. The exfoliated cells from part of the vernix cassosa, a white cheesy protective substance that covers the fetal skin, and the vernix cassosa also includes the sebaceous gland, sebum, fetal hair, and the desquamated amniotic cells. So this is when we see the baby being born, we see this kind of sticky, oozy substance around. The epidermis, the peridermal layer. So it's replacement of the peridermal cells, and it continues until about week 21, and the cells are lost in the amniotic fluid. Thereafter the periderm is normally disappears. So here we can see in a cross-sectional histological slide, we can see the basal and the peridermal part. And as I say, don't worry too much at this point yet. I just want you to have an understanding of these points, and then as we progress through the next few weeks, then we'll start to look at the slides, our histology slides, in more detail. So week 4, week 5, and then we go through into the epidermis at week 11. So by week 11, the basal cell layer forms an intermediate skin layer. So this is now our intermediate skin layer. So if I just kind of go back and show you like an animation. So here we have week 4, ectoderm, mesenchyme. Week 4, embryo is covered by a single layer. Week 5, beginning the second month, we have this division, flattened cells, or periderm or epithelium, and then we have, as we go through, this formation by the 11th week of the basal layers forming this intermediate skin layer. So the epidermis at the end of the fourth month, we can really start to see a lot of proliferation at this point. All of the epithelial layers of the adult epidermis of the skin have acquired their definitive arrangement. We have a basal stratum germinativum, a layer responsible for continuous development of new cells. It later forms genetically determined ridges and hollows which are filled by the underlying mesoderm. The patterns are so formed are reflected on the surface of the skin. For example, the palms, the fingers, the soles, including the toes, in the form of fingerprints. This is called dermatoglyphics, and of course is everybody has a different impression. And so now, by the end of this fourth month, we can see this much more complex arrangement. And so as we progress through over the next few weeks, we'll start to look at these in real slides. There's a thick spinous stratum spinosum layer, large polyhedral cells on top of the basal layer connected by fine tonofibrils. granular stratum granulosum layer. Cells contain small keratohyalin granules, which is the first sign of keratinization. We have a horny stratum corneum layer, which is an outermost layer which forms the scale-like hard surface of the epidermis and is also loaded with keratin. So epidermis and the melanocytes. During the first 3 months of development, the neural crest cells migrate and invade the epidermis to form the melanoblasts and the melanocytes WNT signaling regulation. These cells synthesize melanin pigment in melanosomes. As melanosomes accumulate, they are transported down dendritic processes of melanocytes and are transferred intracellularly to keratinocytes of the skin and the hair bulb. In this manner, pigmentation of the skin and hair is acquired, and so we all have different pigmentation. Dermis is derived from the mesenchyme underlying the surface ectoderm. This mesenchyme is derived from the somatic layer of the lateral mesoderm. So I just want you to remember these points that I'm highlighting for now, because we're going to come back to this, most of it. And the dermatomes of the somites, some. And so here what we can see is an overall schematic. We have the ectoderm, the neural tube, the neural canal, the notochord, and the endoderm. And here we have the rudimentary beginnings of the aorta, the somite, and the somatic mesoderm layers. So these are the different germ layers coming together, fusing. Ultimately they'll fold in medially and cranially to caudal, and we'll start to see the formation process occurring, which we'll talk about. Dermal papier. As the epidermal ridges are formed, the superficial dermal layer or corium projects upward into the epidermis and forms a dermal papier. Papillary loops and sensory nerve endings develop in these papier, and the deep dermal layer or subcorium is characterized by fatty tissue. So some of the disorders which can occur in keratinization are ichthyosis, a group of skin disorders that results from excessive keratinization. This is where too much keratinization rather than not enough occurs. It's characterized by dryness of the skin and fish skin-like scaling. In severe cases, you can have something called a harlequin fetus, which can result, and it's a rare keratinizing disorder that is inherited as an autosomal recessive trait. So I'll just highlight that for your genetics. The skin is very thickened, ridged and cracked, and infants usually die on the first week of life, and its incidence is usually about 1 in 300,000 births. So it's quite rare. Well, it's very rare, but you can see just how devastating it is when it does occur. The collodion infant is covered by a thick, taut membrane that resembles collodion or parchment. This membrane sheds completely after some weeks and occasionally leaving some normal appearing skin behind. Lamellar ichthyosis, autosomal recessive disorder, an abnormal gene on both the autosomal non-sex chromosomes from either parent. The newborn appears to be a colloid baby, but the scaling persists. You have growth of hair may be interrupted, and the development of sweat glands is often stopped. So here you can just see the appearance between these different ones. So do start to take note of these, because these really link in with your other basic sciences courses. Appendages of the hair begin to develop during the 3rd month. but they do not become visible until around the 20th week. Begins as an epidermal proliferation and the hair bud into the underlying dermis. The deepest part of the hair bud becomes cup-shaped, forming a hair bulb, and the hair bulb gets invaginated by mesenchymal hair papier. So here we can see the epidermal ridge, the epidermal layer, the hair bulb, the beginning of the hair papier, and the formation of the hair shaft, which doesn't come until the 20th week. The central epithelial cells of the hair bulb give rise to the shaft of the hair that grow through the epidermis and protrude above the surface of the skin. The peripheral cells of the hair bulb form the epithelial root sheath, and the cells of the epithelial root sheath proliferate to form a sebaceous bud. So here we can see after the 20th week we have the dermal root sheath, the epithelial hair sheath, the hair papier, blood vessel communication, smooth muscle fibres, and the sebaceous gland. Surrounding mesenchymal cells differentiate into dermal root sheath. The erector pili muscles differentiate from the surrounding mesenchyme, and melanoblasts migrate into the hair bulb and differentiate into melanocytes. And so here we can just see the different stages: week 4, week 5, week 12, week 14, week 16, week 20, week 23 to 28. You can see this complete communication. Hairs are first recognisable in the region of the eyebrows, upper lid, upper lip, and the chin. The first set of hairs that appear are fine and colourless and are called lanago. Lanago are shed at about the time of birth and are later replaced by coarser hairs called vellus hairs, which arise from new hair follicles. The vellus persists over most of the body except in the axillary and the pubic regions, where at puberty they are replaced by coarse terminal hairs, seen also on the chest and in the face of males. Sweat glands. During the development at around about 20 weeks, a solid growth of epidermal cells into the underlying dermis form. We have terminal parts and coils form the body of the gland. The central cells degenerate to form the lumen of the gland, and the peripheral cells differentiate into secretory cells and contractile myoepithelial cells, ectodermal smooth muscle cells, which aid in expelling the glandular secretion. Sweat glands, we have apocrine glands in the humans are confined to the axilla, pubic areas and areola of the mammary glands. They develop as down growths of the striatum germinativum and of the epidermis. Their ducts open into the hair follicles and not on the skin surface. They open just above the sebaceous glands. And so we'll start to talk about the different types of glands, ecrine and apocrine, sebaceous glands, and how they work as we get through into the main part of the course. Apocrine glands in humans are found in the axilla, areola, periumbilical region, perianal and circumanal areas, the prepuce, the scrotum, the mons pubis, the labia minora, and the external auditory canal, and on the eyelid region. The exact function of apocrine secretion is not known. The secretory granules of apocrine glandular epithelium resemble zymogen ones and are reactive histochemically for iron, lipofuscin, and neutral mucopolysaccharides. The vernix caseosus is the waxy or cheesy white substance which is found on the skin of the newborn. The vernix is secreted by the sebaceous glands around the 20th week of gestation, and it's composed of sebum, which is the secretion of the sebaceous glands, and desquamated epithelial cells and fetal hair, the lanago hair, which disappears. It protects the baby's skin from dehydration and from constant exposure to the amniotic fluid. The nails, the appendages, begin to develop about the 10th week of gestation as thickened areas of the epidermis at the tips of the digits. Later, these nail fields extend to the dorsal surface and become surrounded by the nail folds. Cells from the proximal nail fold grow over the nail fields from keratinized nail plate to the primordium of the nail. The keratinized cells flattened and consolidate into the compact tissue of which the nail bed is composed. So here we can see the nail field, and we can start to see the formation of the nail plate over the period of the 10th week. The mammary glands begin to develop during the 6th week. I'm going to highlight these times. These times are going to be really important, and you're going to see over the next few weeks why they're so important, especially when we start to look at our different anatomical regions. So the mammary glands, they begin to develop during the 6th week as thickened strips of the ectoderm, mammary ridges that extend from the axillary into the inguinal region. They regress in most locations except in the area of the pectoral muscle where they proliferate. The downgrowth of the epithelial tissue continues to proliferate into 16 to 24 outbuddings, which give rise to lactiferous ducts, and these will be very, very important when we start to look at our histology and especially our histopathology and changes within these ductal systems. Fibrous connective tissue and fat of the mammary glands develop from the surrounding mesenchyme, and the lactiferous ducts at first open into smaller mammary pits. So here we can see the epidermis, the primary bud, primordium of the mammary gland, the secondary bud, and then the branching off, and then we have the formation of these lactiferous ducts. The teeth develop from the ectoderm and the mesoderm. The enamel develops the ectoderm of the oral cavity, and all other tissues come from the associated mesoderm. Not all teeth develop at the same time. The first tooth buds are seen in the anterior mandibular region, later in the anterior maxillary region, then posteriorly in both jaws. And we'll go through this as we go through our head and neck. As the tooth grows, the crown gradually erupts through the oral mucosa, and the mucosa around the crown becomes its gum or gingiva. The crown itself, as it emerges, consists of a nucleus of dentine covered by a layer of enamel. We have something called deciduous teeth and permanent teeth, which again we discussed later on in the course. Deciduous teeth usually erupt between the 6th and the 24th month after birth. Permanent teeth develop later, but in a smaller manner to the deciduous teeth, and as they grow, the root of the corresponding deciduous teeth is reabsorbed by osteoclasts. Fascia, the development of fascia. Fascia is the soft tissue component of the connective tissue system that permeates the human body. It forms a whole body continuous three-dimensional matrix of structural support. We have subcutaneous tissue and deep fascia. Subcutaneous tissue, a mixture of loose areolar and adipose tissue that unites the dermis of the skin to the underlying deep fascia. And the deep fascia an organised connective tissue layer that completely envelops the body beneath the subcutaneous tissue underlying the skin. So here we can see an example. Here's the loose skin on the dorsum. If we made a little incision like we do in the lab, we can see the skin is incised to expose the skin ligaments. We have the skin tissue, the skin ligaments, and we have this deep fascia. And in the example of the hand, we can see if we were to take the subcutaneous tissue, take the superficial fascia away, we can see the deep fascia overlying the muscle. The fascia, ligaments, tendons, reticular and joint capsules. The ligaments, a tough cord, a fibrous band or connective tissue that binds bone to bone or supports viscera. Ligaments. Tendons, a band of dense regular connective tissue that attaches muscle to bone. Reticular, several fibrous bands of fascia, this is bands of fascia, that pass over or under tendons. And then we have the joint capsule itself, the fibrous tissue that encloses the joint cavity of a synovial joint. So all of these things we'll start to go through. And so here we can see a tendon, any old tendon, doesn't have to be a particular one. We have the inner visceral layer of the sheath, and we have the outer parietal layer of the sheath. So we have a visceral and parietal sheath. And these have become really important, especially when we talk about visceral and parietal layers within the body, like visceral and parietal pleura, visceral and parietal peritoneum, the differences between somatic efferents, afferents, visceral efferents and afferents, and understanding of that becomes very important by understanding these terms. Excuse me. Fascia, organ and vessel tunics, membranes or other structures covering or lining other parts, aligning a body part or organ. Epineurum, a fibrous outer sheath of connective tissue surrounding a nerve. The meninges, a group of 3 fibrous membranes covering the central nervous system. I'm just highlighting these things because these are the most important things. The periostea, a fibrous connective tissue covering the outer surface of bone. Myofascia, aponeuroses, a layer of loose connective but strong connective tissue, often containing fat covering the investing the muscles. And so here we can see an example of how fascia is divided. So here we have the muscular compartments, here we have the fib and the tib, posterior and anterior compartments, all divided up by these intramuscular septum. So these fascia are really, really important for dividing up these parts. So why do we need to do this? Why do we have to divide up these body regions or these body cavities? Well, we need it for a few things. We need it for isolation, free movement, and for shock absorption. The parietal serosa lines the internal body walls. Parietal. Visceral serosa covers the internal organs. So remember this, very important. Parietal, internal body walls. Viscera, internal organs. If you eviscerate somebody, you take their internal organs out. Parietal, body wall, 2 very important points. Visceral organs. Serous fluid separates the serosa, so you have fluid between these layers. Here's an example. A balloon. Inflate a balloon, push your fist into the balloon. The outer ball of the balloon is comparable to the parietal serosa. The air is comparable to the serous cavity, and the inner part, which is all the way around the hand, is comparable to the visceral serosa. I hope this makes sense. So we'll start to look at this, an example for the lung, as we go through and look at the chest wall, which we're going to be doing very, very shortly. So remember this: parietal, internal, body wall, visceral, viscera, internal organs. Body cavities. We have a dorsal cavity, protects the nervous system and is divided into two subdivisions. We have a cranial cavity within the skull and encases the brain, and we have a vertebral cavity within the vertebral column and encases the spinal cord. We have a ventral cavity. The ventral cavity houses the internal organs, the viscera, and is divided into subdivisions. We have something called a thoracic cavity, which is our first block. It houses the heart, the lungs, and subdivided into mediastinum, pleural cavities. I'm going to highlight these: mediastinum, pleural cavities, and pericardial cavity. We have the abdominal pelvic cavities, houses the abdominal viscera and the urogenital viscera. It's subdivided into the abdominal and pelvic cavities. And here we can see a schematic cross section through. Cranial cavity contains the brain, dorsal body cavity, thoracic cavity contains the heart and the lungs, region of the diaphragm, abdominal cavity, and the pelvic cavity. Cranial cavity, vertebral cavity, superior mediastinal, pleural, lungs, cardiac, abdominal, pelvic cavity. Remember, covering the walls is the parietal. So in this region we have parietal pleura. In this region we have parietal peritoneum. Parietal pleura, peritoneum. Still parietal. Only when we put the viscera in and we cover the viscera, only when we cover the viscera is it visceral. Other body cavities include the oral and the digestive, mouth and cavities of the digestive, nasal, located within the posterior, within and posterior to the nose, orbital, which houses the eyes, middle ear, which contains the bones, the ossicles that transmit sound vibrations, and synovial, which is where we have our joint cavities. Okay guys, that is the end of our second part. We're going to move on to our third part of our introductory session, and then we shall start to get into our first block's group of lectures. The first block is all to do with the thorax, so please review these videos and go through these concepts that we've talked about, because they're going to be very, very helpful to your learning. Thank you.